Hello, everyone, and welcome to Getting Evidence into Practice, Effective Strategies. Both the chat and Q&A features will be available throughout the session, so please ask questions, make comments, and stay engaged. Thank you for joining us today and for attending the session. Now, I'll turn it over to the moderator to introduce today's panelists.
Thank you, Chris, and thank you, Helen. It was a real delight for us to be able to support the meeting this year. The Council of Medical Specialty Societies is a very important organization to PCORI, bringing together representatives of all the physician medical societies. You know, we really do value the input, the feedback, the engagement that we've gotten from all of you over the years, and we want to see that continue over the years to come. I mean, we have a 10-year reauthorization in hand. We're excited for the future, and we're excited to continue working together to see what great things we can do together. One of those things that we've been doing over the years with increasing energy, you're going to see this energy continue over the coming years as well, is dissemination and implementation. It's not enough to just simply get good evidence published. We got to figure out how to get it into practice much more effectively and much more efficiently. And so I'm delighted that we're joined today by four great colleagues who include Joanna Siegel, the director of our Dissemination Implementation Program, and Chang, a program officer with our D&I group. So they're going to talk a little bit about some of the work that we do inside PCORI to help get better information out there to you. We're also going to hear from two PCORI awardees who are doing some really fascinating and great work to speed evidence into practice. First, we'll hear from Dr. Rachel Berger at the University of Pittsburgh, and then Dr. Elliott Haut from Johns Hopkins. So check out their bios. I believe they're available on the meeting website. And with that, I'm going to get off the stage because there's a lot of great content here, and I want to make sure we have time for it. So I'm going to pass it over to Joanna Siegel. Joanna, take it away.
Thank you, Greg. Hello, everybody. I'm very happy to be able to talk to you a bit today about what we're doing to get evidence into practice. I'd like to give you some background and an overview of what we're doing. And then I'll turn to my colleagues for some more specific examples, including some of the work that the specialty societies have done to contribute to this work. So next slide, please. Just to start out with our conflict of interest statement here. Next, please. So PCORI has a mandate to conduct comparative effectiveness research and develop other evidence in order to assist patients and clinicians and purchasers. That's certainly the best recognized piece of our mandate, but our mandate also does include the dissemination of research findings from these studies to inform practice and to be sure that practice actually reflects and benefits from the research. Next slide, please. It is pretty well recognized that we have a problem with getting from the research to the practice. And I think this is the full reason why that is reflected in our mandate is the well-known language from the IOM some years ago that it takes an average of 17 years for new knowledge to be incorporated into practice. Not sure that's changed much even now. It's definitely continues to be a problem. You can see here from a variety of quotes on this, one of the most consistent findings from clinical and health services research is the failure to translate research into practice and policy where it can benefit patients. Next slide. So what's needed? What can we do about this? It's been recognized as implementation science has advanced that getting research findings taken up into practice effectively is not just a simple matter of making the findings known. Greater attention needs to be paid to actually effective approaches to enhancing the reach of research, its adoption, its uptake into practice. Next slide, please. At PCORI, we have the advantage of being able to take this kind of longer view of our research. So traditionally, research funders have pretty much considered their job done when the findings from their research were published. at PCORI, we're able to take a view that extends all the way to implementation. So from the funding of the research through the release of findings, dissemination, initial steps towards getting the research into the practical setting, and then broader implementation as we put it on the road to uptake. Next slide, please. Before we get too much further, I want to define some of these terms as we use them and consistent with the literature from implementation science. But release of findings are activities to basically just make the research findings available and accessible. Dissemination is our process of essentially getting findings to audiences that can use them. The goal of dissemination activities is to increase awareness, motivation, and ability to use evidence. Implementation is the process of actually integrating evidence into policy and practice. Involves adapting evidence to different contexts and actually facilitating the behavior change and the uptake of the evidence at the point of care or otherwise where it's used to affect decisions. Next slide. So I'd like to start with a focus on our implementation work, which is what you'll be hearing a bit more from Rachel and Elliott about. Next slide, please. So PCORI's implementation funding is where we really look to our awardees, and these are awardees who have implementation projects, not research projects. They are doing the hands-on work of taking an intervention that has been shown to work in research into a specific practice setting, crossing that divide from the research setting into the real-world healthcare. We look to our implementation projects to actually demonstrate that an approach works, that it actually can get evidence taken up into workflows and into standard practice, and to build the basis for broader uptake down the road. We have 3 funding initiatives in the D&I program. The first one is our limited competition, which is specifically focused on our PCORI investigator teams, giving them the opportunity to take what they've learned in the process of stakeholder engaged research and actually building on their experience to propose the next steps to get their research into practice. We also have a funding initiative that focuses specifically on effective shared decision-making approaches. We look at shared decision-making as clearly a very patient-centered approach and very much consistent with PCORI's patient-centered mission, but also one that directly pulls evidence from research findings and puts them directly in front of the patient and the clinician in decision-making settings. So we have a specific emphasis on that. Our third funding initiative is designed to really move findings from some of our major focuses in research out into practice. So what do we look for when we're doing implementation? We basically are looking to apply the lessons from implementation science and really try to figure out what works to get a study from that research context and get its lessons into practice. We look for strong evidence. We look for an active implementation strategy that's multi-component, one that's evidence-based, been shown to work in other settings. We look for an adaptation of an intervention. All implementation is said to be local. There's always a tension there. We look for fidelity to what was actually tested in the research, and yet realize that a certain amount of adaptation is going to be necessary for any given setting. We put a strong emphasis on involvement of frontline staff in any type of implementation because they are the critical linchpin, as well as buy-in from the sites, from leadership and others who are in the position of making decisions for their organization. We look to sustainability. A project needs to be able to work during the span of the project, but it also has to be sustainable going forward. We also look to document both the delivery of the intervention in a project and also that once delivered, it's still working as it did in research. Next slide, please. These are examples of the type of obstacles that we know to expect from all of those studies on barriers and facilitators to uptake that are now in the literature. There's certainly a lot of common themes, and most of our awardees who are working on implementation directly address these issues. So for example, that an intervention is unfamiliar to providers or other staff, it's not part of their current practice. The projects put a special emphasis, as I mentioned before, into interventions, into training or other processes that actually move these effectively into existing workflows and staff responsibilities. And those strategies might include, for example, consultation or site visits, learning collaboratives, on-site champions, and they're going to likely include more than one of these. Often when we are looking at a newly tested intervention that's newly been found to be effective or relatively effective compared to its comparator, the research study may have relied on paid researcher site staff to deliver the intervention. Getting staff at the sites trained and involved is a whole different focus for an implementation project. Next slide, please. At this point, we have been working for about 5 years doing implementation at PCORI. From the point in time, 2016 was roughly when we started getting results back from our funded research. At this point, we've funded almost $50 million worth of implementation projects through 35 awards, and we've completed a number of funding cycles to date. We do about 3 to 5 per year for the different awards that I mentioned. I'd like to talk just for a moment on the other aspects of the program. Next slide. The thing that we do for all of our research, just to assure the transparency of what we do and to make our findings accessible, is to post the public abstracts of findings from every research study. This is something we're mandated to do, and we're also mandated to do it within 90 days of when the studies clear our final peer review process. So at that point, we publish for every study a public abstract, which you see here on the left. That's what it looks like in the posted form. It's at a 6th to 8th grade reading level. We cognitively tested the template for it, so found that a question and answer style works best. We lead with the results. We highlight elements that address the personal relevance to readers. We also have a downloadable PDF and a Spanish version. The PDF is what you see there in the inset. We also have a professional abstract, which more closely resembles a standard research abstract with a PICO box and the more detail on the technical elements of the study. So this is what we do for all of our findings, but for some of our findings, we're also able to pursue more active dissemination. That is to say, the efforts to really try to get specific findings to audiences that can use them. And for this, I'm going to turn this over to Chang, who's going to talk about some specific activities we do in targeted dissemination.
Great, thank you, Joanna. So as Joanna said, I'm going to talk for the next few slides here about our targeted dissemination efforts at PCORI. So beyond making our research results available to the public on our website, as Joanna touched upon, for select findings that we feel have clear potential to inform healthcare or other health decisions, we go a step further and create evidence resources to help support dissemination of those findings. So as we've touched on, disseminating research findings to targeted audiences is important in raising awareness, ability, and motivation to use the evidence. And so as a first step in our targeted dissemination work, we create resources, which we call evidence updates. The evidence updates distill main findings in a digestible and comprehensible format from one or more PCORI-funded studies or from systematic reviews. They are one-page front and back resources, and they are both written and designed to reach specific target audiences. And the evidence updates really drive our dissemination activities with stakeholder organizations. We consider them to be an entry point for us to discuss new evidence and ways that we can bring that evidence to audiences who can use it. Next slide. So we currently have evidence updates on 7 different topics, all of which are available on our website. And you can see on the right side of this slide some examples of recent and upcoming topics. And on the left, we have an example of one of our completed evidence updates. This is the one on reducing risk of stroke in patients with AFib. We created a version for clinicians, which you can see in the back, and then a version for patients, which is in the foreground. We've built in multiple touch points with stakeholders throughout our development process to help inform our evidence update content. So first, before we even start working on the first drafts of the evidence updates, we have key informant interviews with stakeholder organizations who are working with the targeted end users for these resources. We ask for input and perspective on questions like, do you see value in disseminating these findings? What key messages are important for your constituencies? And what dissemination vehicles do you typically use to reach your audiences? And then we incorporate what we learned from these interviews to shape the messaging in the evidence updates and our plans for dissemination. We offer an opportunity for stakeholder organizations to review the evidence update drafts once they are available. And we also work with interested organizations on co-branding the final resources. So you can see along the top of the stroke AFib evidence updates that they're co-branded with several stakeholder organizations, including the Alliance for Aging Research and the American Academy of Family Physicians. And once the evidence updates are complete, we also work with organizations to support stakeholder-led dissemination activities. Next slide. So here are some examples of some of those stakeholder-led dissemination efforts that we've worked on with medical specialty societies and others for findings from PCORI evidence updates. Some common dissemination vehicles have included website links, social media, membership newsletters, blogs, patient-facing magazines, topic briefs, resource toolkits, webinars, and hard copy distribution. So these efforts can all help contribute to spreading knowledge and information amongst patients, caregivers, clinicians, and other audiences to make better informed healthcare decisions. And working through established targeted channels from trusted organizations is an important way to reach those audiences. Next slide. So next, I want to give you a closer look at one of our evidence update topics and some of the examples of our related targeted dissemination efforts. So this evidence update summarizes findings from a PCORI-funded systematic review update on non-surgical treatments for urinary incontinence in non-pregnant women. And the report was done in partnership with the Agency for Healthcare Research and Quality. So the report found that several non-surgical treatments can improve or even resolve symptoms of urinary incontinence. Effective treatments differ by type of urinary incontinence. Almost all of the study treatments were more effective than no treatment, and most women were satisfied with the treatment that they received. So we felt that these findings were important to disseminate because urinary incontinence affects millions of women in the US, including 25% of women of reproductive age, and it becomes more common as we age. But despite this prevalence, many women hesitate to seek treatment because they may feel embarrassed to talk about it, or they may be unaware that improvement of symptoms is possible. Next slide. So our dissemination goal for these findings is to reach women who are unfamiliar with non-surgical treatment options for urinary incontinence and their clinicians. So therefore, we created 2 evidence updates for this topic, targeting each of these audiences, women and clinicians. They were developed with consultation from patient and professional organizations, and they're co-branded with the National Association for Continence. PCORI ran a LinkedIn ad campaign for the clinician version of this evidence update. We targeted urologists, geriatricians, and primary care practitioners. And we received over 2,000 clicks to the evidence update from this campaign and over 1,100 social actions, which included likes, shares, and comments. We also worked with AHRQ to convene representatives from 28 stakeholder groups to discuss dissemination and implementation opportunities and strategies for these findings. Participants represented a variety of stakeholders, including clinical professional associations. And based on input and feedback from this workshop, AHRQ has announced a notice of intent to publish a funding opportunity announcement to improve the non-surgical management of urinary incontinence in women. Next slide. And since completing the urinary incontinence evidence updates, we have worked with several stakeholder organizations to disseminate the findings to their constituencies who specifically could use this information. And I've highlighted 2 examples here. So starting with the Urology Care Foundation, which is the official foundation of the American Urological Association, they strive to provide the most current and reliable urologic health information for patients and the public. And we worked with them to feature these findings in an episode of their podcast called Urology Care Podcast. And the episode featured an interview with a urologist who was also the AUA representative who had reviewed the evidence update drafts and participated in the PCORI AHRQ stakeholder workshop. We also published a guest article on their blog called Care Blog, which highlights the urinary incontinence evidence updates, the report findings, and also the podcast episode. And AUA also invited PCORI to present about the findings from the urinary incontinence systematic review update at their 2019 Bladder Health Alliance meeting. And they featured the report and the evidence updates in the pre-meeting materials. We also worked with the American Geriatric Society to disseminate these findings. Their mission is to improve health, independence, and quality of life of older people. They participated in a key informant interview, providing insight and context for the report findings and their constituency, which helped us shape our key messages for the evidence updates. And then once the evidence updates were completed, they were featured in their weekly membership newsletter. And a physician representative also participated in the PCORI AHRQ stakeholder workshop. Next slide. So to wrap up, I just wanted to emphasize that, as we all know, medical specialty societies are trusted sources of information and are integral in successfully reaching clinicians with new evidence that can benefit their patients. So we hope we can work with your organizations to disseminate the findings from relevant evidence update topics to your constituencies. And PCORI also offers support for professional and other stakeholder organizations to disseminate evidence from PCORI-funded studies through our Dissemination Engagement Awards. And our evidence updates can serve as a source of evidence and a basis for dissemination activities for that opportunity. That's the end of the presentation.
All right, thanks, Jane, and thanks, Joanna. Let's go ahead and move on over to Dr. Rachel Berger. If you can, if anyone in the audience has questions, please go ahead and put them in the chat, and we'll get to them once Dr. Berger and Dr. Haut have both made their presentations. Dr. Berger, over to you, ma'am.
All righty. So today I'm going to talk about dissemination and implementation of a child abuse clinical decision support system, which is the grant that I have funded from PCORI. So thank you for the opportunity to talk to you about this today. Next slide, please. I don't have anything to disclose. Next slide. So just a little bit of background. I think we can all agree child maltreatment is not a good thing. We have about 3.5 million referrals in the United States every year, a little less than 750,000 children are substantiated as victims of child maltreatment, which is almost 1 in 100 children in the US every year. We have a very high death rate from child abuse. About 4 children die every year in the United States from child maltreatment. We have one of the highest rates among industrialized countries. We are actually right next to Mexico. And the number of maltreatment deaths has actually been increasing over time. It went up 11% in the past 5 years. So this is not a problem that's going away, and something, I said, one of the leading causes of death for children in this country. Next slide, please. Early identification of child abuse is key. Many children who are injured or die from abuse have been seen by physicians for injuries which in hindsight were likely due to abuse, but for whatever reason the diagnosis was not recognized. And the proportion of abused children who were initially misdiagnosed has been relatively stable for 15 years, despite many efforts at intervention, particularly at education. We know that as medical professionals, we don't consistently screen for abuse, even in objectively high-risk situations. And like other forms of violence, abuse is a cycle and tends to increase in severity and violence over time. Next slide, please. Child maltreatment has a profound impact on children's lives. Being a victim of maltreatment is among the most significant ACE a person can have and has a strong association with substance abuse, mental health, and mortality in adulthood. Next slide. So what do we need to do to try to protect children who have been maltreated? This is a paradigm we first presented to PCORI in 2012. And this idea is that we have to identify the suspicion of maltreatment. We then have to alert physicians that there is a suspicion. We have to help physicians properly evaluate for maltreatment. And then if they need to report to Child Protective Services, we need to help them reporting so that they provide a clear statement to Child Protective Services. That handoff of information between the medical professionals and Child Protective Services is what it needs to be in order for Child Protective Services to protect that child. And every one of these steps needs to be supported in order to protect children and to be part of a child abuse clinical decision support system. Next, please. So how have we defined success? We've got a lot of different ways to define success. One is that more children with suspected abuse are identified who might otherwise have been missed. We hope to see increased appropriate reporting to Child Protective Services, but without over-reporting, and that's a really difficult balance to get. We'd like to see improved compliance with the American Academy of Pediatrics guidelines for evaluation of child physical abuse. We'd like to see improved documentation of Child Protective Services reporting within the electronic health record, because if physicians don't know that there have been multiple prior reports, then they can't properly assess the child, since violence is often a pattern. And our ultimate clinical goal is to decrease the number of children who have clear previous opportunities to identify abuse. And this is actually much harder than it might appear, because children can get medical attention from a large number of places and move very quickly between insurers. We also, from the start, have wanted to address the issue of racial disproportionality. Next, please. The issue of racial disproportionality in child maltreatment is a well-recognized issue. Studies consistently show that as medical professionals, non-white publicly insured children are much more likely than white privately insured children with the same injuries to undergo screening and reporting for child abuse. And referral rates to Child Protective Services for Black children with the same injuries are higher than for white children. Next slide, please. There are multiple points in children's involvement in the child protection system where we introduce some disproportionality, but actually the place where it's most pronounced is actually in the referral stage. In Allegheny County, which is the only county that I was able to find clear data, there are 3.9 Black children and 2.3 biracial or multiracial children referred for every white child. And that's a tremendous amount of disproportionality. At each of the other stages, it's about a 1.1 to 1. So the most disproportionality is actually introduced at the very beginning of the system, where physicians are most involved. Next slide, please. These are some of the papers that we've published, and clearly I can make all of these available to you, about what we've done in terms of putting in a child abuse clinical decision support system within Cerner, within our Children's Hospital of Pittsburgh hospital, and within our 19 general EDs in our healthcare system. Both have Cerner, but they have two platforms of Cerner. So they actually we have entirely different electronic clinical decision support systems, because they're two different systems within Cerner. The other thing I want to point out is we implemented the first system-wide child abuse screen, which occurs in all children under the age of 13 who are seen in any of our 19 general EDs. So this was, as I said, an early grant from PCORI. We are now about 4 years out from this grant, and these systems are all still functioning as part now of clinical care. Next slide, please. So the dissemination implementation grant was to see if we could take what we had learned at the University of Pittsburgh Medical Center and expand to other health systems that have a different electronic health record. So as I mentioned, we have Cerner. Cerner makes up about 25 or 28% of the US market. And so clearly that's not going to be easy. That's not going to affect all children. So we expanded to Epic at the University of Wisconsin and Allscripts at Northwell Health System in New York. Epic is actually the most common healthcare electronic health record in the emergency department. Allscripts was actually number 3 at the time we did this, but actually it's moved down a little bit and there's some other electronic health records. It's important to realize that Cerner and Epic and Allscripts, between those 3, you have about 55, 60% of the market, but all the other players are about 5% or even less. So there's multiple small players in the electronic health record space. So our success was we did integrate child abuse clinical decision support in both of these. They have been live for about a year, and I'm going to talk a little bit about that. The barriers, some of them were very predictable, some were more unpredictable. Some of these were technical, and we recognize this from the start that it's when you go into each electronic health record, it is like starting from scratch and you need to recode. Cerner codes differently than Epic or Allscripts. And we recognized this before, but still it's a big undertaking. And so what we needed to do was essentially a crosswalk for each trigger. So anything that alerted in the children's hospital or the our general EDs, we had to see whether that similar chief complaint or that similar order existed in these other systems in order to crosswalk them, because the sensitivity and specificity of the system was developed in Cerner with specific chief complaints, specific orders, and other specific discrete fields. The IT issue, we recognized from the beginning that you need a tremendous amount of IT support, but we also came to realize how unpredictable some of the issues related to the length of queues, the expertise in IT, the turnover in IT, all those things you really can't control and are, I think, by nature unpredictable, have a tremendous effect on whether you can actually bring something to clinical care. Administratively, as this started, the Northwell Health System was promoting a big change. So they didn't want any more alerts or interactive alerts because they had felt that there was too much alert fatigue. And our pop-up alert is what we had used in Cerner. That's what we also used in Epic, but we couldn't do that in Northwell because they had made the decision they wanted to move away from active alerts and move toward passive alerts. So sometimes you have to change because of much larger issues in the healthcare system. And then of course there's human issues, turnover of staff. We lost the child abuse pediatrician in both of the hospitals that both of the hospital systems that we were integrating in, which was not something we had considered. And so we had to figure out how we were going to implement a child abuse clinical decision support system without a child abuse pediatrician. And then there was really a lot of resistance to change, although it was more about the clinical decision support in general rather than child abuse in particular. Next slide, please. So as I mentioned, child abuse clinical decision support has been live for over a year. They both went live in April, May of 2019. So it's almost 18 months at this point, in multiple hospitals in this system and in both pediatric and general EDs. They have all transitioned from research to clinical practice at this point. But again, the implementation had some predictable and some unpredictable barriers. Technical was one we hadn't really considered only because it did not happen at all in our system. There were 2 silos of communication, 2 silos of people, the technical and the clinical, and there was very little communication, particularly in Northwell, between those 2. And that created a lot of issues, which we now could deal with a lot better, but hadn't predicted. The inability to develop data reports actually has been an issue in every healthcare system we worked with because of, again, a siloing. The people that create the data warehouse reports are not the same people that code. So you might be ready to go live from a coding perspective, but you have no data report. And those people can't tell you when you're going to be willing to, when they can bring you a data report. But if you wait on going live with the system, you might have an Epic upgrade or something that will put a freeze on everything for another 6 months. So balancing those 2 was an ongoing issue with all of our sites. And then I think the barrier is human. We knew that culture change was hard. We had champions at every site, but still it is hard to change culture, particularly on something which is quite sensitive like child abuse. There were a lot of forces outside of what we were doing in particular. If a hospital or hospital system has a perception of child protective services as not helping families, for example, they may not be reporting child abuse, even though objectively they should, but they have their own concerns about how Child Protective Services is going to respond. And those kind of personal concerns or even system concerns are very strong drivers to not want to have change. Next slide, please. So were we successful? These were the parameters we set out at the beginning. Were we going to be able to identify children with abuse who might not have otherwise been identified? The answer was yes, we clearly did. Were we able to increase reporting without over-reporting? Yes, we clearly did. However, none of the hospital systems had the ability to consistently track whether reports had been filed with Child Protective Services before we implemented the child abuse clinical decision support. So it was not as easy to tell, and some of the increases might have been due simply to poorer documentation. So the system going to place, everything had to be done by hand. We had to look through hundreds and hundreds of social work notes to see if reports had been filed. So by nature, there's a bias in there. But we did not appear to cause an increase in over-reporting. We did, so in terms of improving compliance with the American Academy of Pediatrics, our analysis is ongoing for both Northwell and the University of Wisconsin. Improved documentation within Wisconsin, they implemented a specific form that helped with the documentation process, and clearly it did improve over time. In Northwell, it was more of an acknowledgement, and the issue is that the social workers who are reporting actually don't document with an electronic health record. They document in a totally separate record, and so it was very difficult to show improvement in documentation. And hopefully at this point, the system is actually thinking of integrating social work documentation outside of the child abuse realm, but for everybody, which I think will greatly improve the documentation. There is a form, it's just sitting in a different record. Next slide, please. The ultimate clinical goal, as I said, is to decrease the number of children with previous missed opportunities. And we have some early data that suggests that we are improving it. It's data from our healthcare insurer, which shows that since we started our clinical decision support system within the University of Pittsburgh, there are fewer children being missed. But actually interesting, what is more pronounced is that the number of missed cases compare it with children who seek care at our hospitals versus non-UPMC hospitals where UPMC insured children are going is actually increasing while ours is decreasing. So they're actually diverging, which suggests that we're doing something that's improving or decreasing the number of missed opportunities. In terms of decreased racial disproportionality, yes, we seem to be showing a decrease in racial disproportionality, and none of the screens that we've introduced have actually shown any racial disproportionality, which is very important because our concern was with a child abuse screen, which is done by a person and is subjective, could increase the racial disproportionality, and we did not see that. Next slide, please. So how do we move forward and how do we bring about widespread dissemination? Is there a desire to do it? Yes, I think overall there really is. Missing child abuse is a defining moment for many physicians. JCAHO does require child abuse screening, and many, many hospitals are asking us to put in systems in their hospital because they want to have this type of clinical decision support. Will it get easier over time? Yes, we have also expanded with different funding to 6 hospitals with Cerner, and within the Cerner system, we are getting much better at it. And most recently, one of the hospitals we work with was live within 5 months of deciding they wanted to put child abuse clinical decision support in. Novel electronic health records are challenging, but things like FHIR, the technology may be improving so that we can develop a system that's actually agnostic to the type of medical record. And I think the most important are there ways to offer financial support and incentives for hospitals that do this through the insurers, potentially Medicaid, since that's the primary insurer for most children who are triggering our child abuse clinical decision support system. Next slide. So we need consensus at every level that this is important in order to actually disseminate this information. Next slide, please. This past week, we held our 3rd annual and our first virtual Child Abuse Clinical Decision Support Conference. It was 8 hours over 2 days with the goal of creating a consensus statement about child abuse clinical decision support in pediatric care. We had over 125 participants, 20 hospitals and hospital systems, and 10 national organizations that sent a representative. Next slide, please. 3 of those, which I highlighted, the AAP, American College of Emergency Physicians, American College of Surgeons, are part of CMSS. The other ones, you probably recognize many of them, and they all sent representatives to this consensus conference. Next, please. So I think there are some potential opportunities for collaboration with CMSS. I think you have an important voice with overlapping goals of what we're working on, particularly the role of racism in healthcare, the Disclosure Harmonization Task Force, and of course, advocacy. And there are probably societies within CMSS that we should be reaching out to help disseminate this information. Next slide, please. So that's on to end there, and I will leave questions for the end after the other presentation. Thank you.
All right, while we make the transition, Dr. Haut, you're up next. Glad to see you with your camera on. We'll turn the floor over to you.
I'm ready to go as soon as I see the slides.
Liz, do you have Elliott's slides ready? Or Chris? Guess you could dance or sing or something. There we go.
Neither of those.
There you go. Sorry.
We're getting closer. We're getting closer.
There you go.
Perfect. That's me. So I'm going to set my timer so I hopefully try to stay on time. I'm going to talk today about implementing an effective program for preventing blood clots in hospitalized patients. Next slide. I put up a few disclosures. They're mostly grant funding, board membership as it relates to these projects. Next slide. So these are my objectives. We're going to talk about VTE, or venous thromboembolism, as a public health concern, and then talk about potential D&I outcomes, and then I think really focus on the lessons learned about D&I in real world settings. Next slide. So I put this up as my reminder to say that venous thromboembolism is bad. It kills 100,000 people per year, more than breast cancer, AIDS, and motor vehicle collisions combined. And we know that we as a medical community don't always do a good job providing optimal prevention for patients, or for VTE in hospitalized patients, and about half of these events are associated with hospitalization. Next slide. So we've been working on administration and risk assessment and ordering appropriate VTE prophylaxis for over a decade now. But more recently, we turned our attention to this question. As clinicians, we assume that a medication gets ordered and it always gets given, but is that really truly the case? Does prescription equal administration? And I think it's critical to understand, at least in VTE prophylaxis and many other fields, the prescription is a key first step, but then a nurse administering these medications to a patient who accepts it is the next important phase. Next slide. So it turns out that about 12% of doses of VTE prophylaxis are never administered to patients, and that's what really prompted our first original PCORI project. This was one of the papers that came out of that. It's about patient preferences for receiving education about venous thromboembolism prevention. When I presented this at PCORI, I circled the two patient co-authors. Both Susan and Paul were pulmonary embolism survivors who were involved in our project. Next slide. So we took that material or their input from all these patients and created patient educational materials that are freely available. Bit.ly blood clots will take you there. You can tweet at me and I can tell you how to get there. Our YouTube video is closing in on 200,000 views. So for patient education material, I would say that's doing quite well. And that was all funded by PCORI. Thank you. Next slide. These are two of the research projects about our original project, the first of which was a nursing education module where we educated nurses using a short online interactive education tool. And we showed that after the nurses did that education, their clinical practice changed and they were more effective in giving a higher proportion of doses of these VTE prophylaxis medications to patients. The second one looked at our patient education bundle. We did an intervention using the education materials I showed you, paper tools, both in English and numerous languages, as well as this video education and used that for talking to patients who were refusing these medications, educating them, and that showed approximately a 50% decrease in missed doses. That was done on 4 floors at our initial intervention hospital with our initial PCORI project. Next slide. So where did we go from there? So after we showed that this intervention worked on that one area, we were able to get additional funding from PCORI for dissemination and implementation. So we went from 4 floors at Johns Hopkins Hospital to the entirety of the 1,000-bed large academic medical center. And we also intervened and put our project in place at an entire non-teaching hospital, community hospital, Howard County General, which is part of our health system. So that's already been completed. And then most recently, we're in the process, and I'm going to tell you a little more about scaling this intervention to 10 trauma centers across the country with a second D&I award from PCORI. Next slide. So here's what I showed you. If you want to get more information about the first, the generalizability is always these questions of how can we generalize our research findings. This went from, like I said, 4 floors to 2 whole entire hospitals. You can find out more information on the PCORI website here. And on the next slide, this is our CLOT3 study. So we were already part of a group called the Consortium of Leaders in the Study of Traumatic Thromboembolism, CLOT. That was a group of 17 trauma centers across the country that were doing large-scale research in the topic. 10 of those centers are now part of CLOT3, which is the intervention arm, the scalability of the intervention I already told you about. You can find more information, like I said, at the PCORI website. Next slide. So I think it's important, especially for researchers who might not know as much about dissemination and implementation. I think Joanna gave an excellent overview of the topic, and it's really important to think of these outcomes as you're planning these types of projects. There's many different frameworks that can be used, but so this is a list of some of these implementation outcomes, things like acceptability, adoption, appropriateness, implementation costs, feasibility, fidelity, penetration, and sustainability. And this is from a paper about this topic of dissemination and implementation, specifically in trauma, but it applies to many other fields as well. Next slide. So some tips and tricks that I've learned along the way of doing this, this implementation over the past few years. Be ready to change parts of your intervention. Your proposed intervention may not be accepted as is. Rachel gave us an example of this in her project, where the one health system said, yeah, we're not doing these kind of pop-up alerts. So you just have to change with the flow because they're saying no. Joanna mentioned our project that our original project, we had a dedicated nurse educator who was part of our PCORI funded team who went and did a lot of these interventions. That person was able to cover 4 floors. They were not able to cover, 2 entire hospitals. And the hospital certainly wasn't going to go hire 10 people just to do this. So how do you change appropriate parts of your intervention while keeping it, amenable to the way it was originally planned? That's this question of fidelity. Is it really the same as it was in the beginning? And will it show the same intervention and the same effect size? Cost is always a big issue. PCORI paid for this nurse educator. Our hospital's not going to pay for 10 of them. Next slide. I think it's important to get some stuff in writing. I'm certainly not a lawyer. I'm a trauma surgeon. I'm an implementation scientist, but it is nice to be able to go back as, for example, if a hospital president leaves or a director of nursing or a chair of a department, and go back and say, hey, I understand you don't know about this project, but your predecessor wrote us a letter of support and sent it to PCORI saying you'd be involved and you would work on this and you would do this. It's really hard for me to do my project now when you've changed your mind. So I think those types of things are very helpful, especially as it takes a while to get these projects funded and then actually implementing them. Be prepared for the turnover and be ready to go with some gentle asks of the new people. Next slide. Be prepared to battle with bureaucracy. Many committees are needed to approve educational rollout. We were not able to snap our fingers and make it happen. You often have to go to the right committee who's going to then have to approve this thing. You also have to figure out where is the decision made. Is this made at a hospital system level that one person can make the decision, then it goes out to, 5,000 beds covered by all these different hospitals? Or is it hospital by hospital? Or is it functional unit? Or do you have to go talk to each individual nurse manager on every floor to get something done at the floor level? Very, very difficult questions to try to answer. If you can make a hospital system agree and sign on to it, it's great, but it still doesn't fix the fact that the people on the floor might not be really doing it. Are there different pathways for different hospitals? We found that's absolutely the case at our large academic medical center with lots of bureaucracy, which might be different than at a smaller community hospital. And then the informatics and electronic health record interoperability, all these issues and bureaucracy of who makes those changes in Epic as an example, and who's allowed to approve it, and how do you get to the top of the queue are big questions. Next slide. I think you also have to be ready to advocate for long-term continuation. What happens after the funded research phase is over? We were saying, hey, we've done this research, it worked really well, it's up and running on these floors. We don't have any more research funding, that project has ended. How do we keep that going? Who's going to take it over? Who's in charge of sustainability? Who pays for it? Our thing was relatively cheap. We had pagers, they had a small cost associated with it, but someone had to actually pay the costs. And then the other piece is, can you still stay involved? We started this project, it took us years to get it going. I was the PI, we had nurses who really put a lot of their time and energy and blood, sweat, and tears into this. And then all of a sudden, when it gets turned over to another group, do you still get a voice in it? It's a tough question. Next slide. I think the important piece is to find the allies. So at Howard County, it was a small core group of nurses, physicians, and quality leadership. I had 2 doctors, 2 nurses, and 1 person in quality who all really loved the project and wanted to be heavily involved. And they were great, and they were critically important. At Johns Hopkins Hospital, it's a much bigger behemoth, and they literally had to create an entirely new community and committee within nursing to help this project move forward. Next slide. Always be prepared for the next step. D&I isn't complete until it's spread everywhere to every possible appropriate setting. Next slide. So you already saw this one, and I'm going to tell you a little bit about this project. It just kicked off. It just got funded. Contract just recently signed, backdated till September, and we've been working on it hard. We had our kickoff meeting just a couple weeks ago. Next slide. And our key stakeholders are shown on here. And I think it's important to realize that some of these are organizations involved in CMSS, the American College of Surgeons, specifically the Committee on Trauma. There are other professional societies that are smaller, and those are both physician, nurses, and there's other groups that are patient-centered. And in our case, they're blood clot-centered organizations and patient safety. All of these key stakeholders are important to bring together as you're trying to get this kind of work done. Next slide. I think it's critically important to add on the role of the professional organization. I've had the honor and privilege of being a president of one of those organizations. I was the past president of the Eastern Association for the Surgery of Trauma. If you're wondering why I'm wearing a ridiculous Hawaiian shirt, this is because this is our official garb at our organization, and you can actually see the East logo on here right now. But for me, it's obviously been very personally rewarding. There's lots of collaboration and colleagues, lots of education funnels through these groups, lots of research and mentoring and career development. And that's critically important. On the next slide, I want to add in one other piece where these organizations can be even more helpful. So one of our key stakeholder groups is the American College of Surgeons. Our application to PCORI had 106 pages of letters of support with over 100 letters from organizations, individuals, key stakeholders, local people at each site. And this is directly out of the letter of support from the American College of Surgeons Committee on Trauma. And it says, I anticipated that if your team can show feasibility at this small but influential group, and that's these 10 trauma centers I just mentioned, we would plan to help scale your intervention throughout all 800 trauma centers in our trauma quality improvement program. This is the kind of role that professional organizations can play, whether it be in research or, as we're talking about today, in dissemination and implementation. That's the next step, scaling from 10 sites to 800 sites. And that's my goal of where I would like to see this project go. Next slide. So with that, I'm going to close, and I guess we're ready for questions and answers. Thank you very much.
And Jane and Joanna, if I can ask you to bring your cameras back up as well. There's Helen. This is an opportunity now for you, the audience, to ask any questions that may have come up throughout the presentations. Just while folks raise their hands or type their questions into the chat. You know, Rachel and Elliott, you guys had mentioned that specialty societies have been involved in your projects. Can you talk a little bit about the stage at which they initially became involved and how that happened? I think that would be something, you know, that would be interesting for all of us to learn a little bit more about.
Rachel, you want to go first?
So it's an interesting question because I was just talking to somebody about this the other day. So we had our consensus conference this year, and that was the first time we had officially involved the national societies. And part of me thought that it was actually too early because we were just finishing, you know, our first dissemination with these 2 other electronic health records. And then at the same time, I thought, you know, if we wait any longer, then there won't be an opportunity for the societies to potentially have an input as we continue to disseminate. So I think it's a really tough decision because you don't want to bring people in too early before your evidence and your data are there, but you don't want to wait till it's too late because in that case, it's very hard to make changes or to bring in the expertise from the societies that may help you to make your project a better project and the actual dissemination process better. So I think it's a hard question to answer. But for us, I said it was clear last year at our second annual conference, we were not ready at that point. And this year, I think we were much more ready. And I think the input of the societies actually was very, very critical at this stage of consensus building. So I don't think there's a right answer, but I think it earlier rather than later is what I would say.
I would agree with that, the vote early, vote often approach. So with our initial PCORI project, we actually didn't have any specialty societies involved because blood clots are such a cross-cutting issue. They apply, you know, I'm a surgeon, but it wouldn't just be surgery. It'd be surgery, internal medicine, you know, emergency medicine, hematology, all, I mean, everybody, OBGYN, like what specialty societies would you pick and choose? We did, however, have key stakeholders about other blood clots. I think that's a different question. But as far as the specialty societies, once we have now narrowed down our focus of this next dissemination project, it was critical to get them on board up front. So I would say every important national trauma organization has gotten behind this project. Every single one. You know, it was easy for me to ask East. I was the past president. I said, hey, would you be willing to support this? That was easy. But the other ones were very willing to do so as well because they realized the importance of high quality research, but also the dissemination of research into these trauma centers and realized that they can be the conduit. So when I talked to the American College of Surgeons, they were the one, they're the, you know, the 800-pound gorilla. And if I said, hey, if I can get this to work, could I move that into your program? I'm willing to give it to you for free into the TQIP program. And then it's out to all the trauma centers across the country. And getting them involved early at that planning phase, I thought was absolutely critical.
That's a great point, Elliott. I'll just jump in here. I think the other question it really is, how can we help facilitate some of that early engagement, even at the idea stage? You know, when I was at ARC, we spent a lot of time on the translating research into practice phenomena. And there's just no question that when your end users are at the table from day one in your research, you're so much more likely, as you've both demonstrated, to have that kind of reach. And the other interesting thing is, given the pandemic, what we've also seen, and there were a couple of sessions on COVID-19 and clinical registries, for example, is there is this bit of a burning platform currently that allows for that cross-society work. You know, for example, there's a registry that goes across critical care medicine, infectious disease, radiology. That's the kind of secret sauce, I think. So, you know, maybe one, you know, thought would be, as even if people are thinking about what their research is going to look like, how can we, you know, again, even the CMSS, how can we help facilitate getting you to those who might be able to bring it through and give you a national perspective, even if your initial project is local, as you pointed out, Elliott, and sort of watch it grow, but think about that larger concentric circle from day one.
Well, I think what I'm going to do is I'm going to tap into you and tap your brain and say, hey, you know, now that we're going to 10 trauma centers and we have a pathway for the rest of the trauma centers, and that's, you know, my interest as a trauma surgeon, but also blood clots, like I said, affect everybody.
Right.
Maybe our next key stakeholder as we go to scale this everywhere is CMSS, which then talks to the neurosurgeons and the obstetricians and the everybody else who does this. Maybe that is one way.
Absolutely.
As we scale this up, because our intervention, you know, we're targeting trauma right now, but we initially did it for medical and surgical patients, and it could go everywhere. It's now, you know, we do this on the neuroscience floor. We do it on the OBGYN floor at Johns Hopkins Hospital. That might be a way for CMSS to help us. So luckily I have your email.
Good. I was going to make that comment. Actually, both of our projects are similar insofar as child abuse was the same way. So like the AAP was an obvious partner. And from the very start, actually, the AAP was on our stakeholder committee. Our stakeholders are a little unusual because of the population, but we had some societies on our stakeholders from the very start. But it was later that we kind of worked with the Trauma Society because our focus was emergency medicine. But I think we had the same issue with Elliott is there's just everybody touches child abuse. I mean, you literally, no doctor that isn't a mandated reporter that has never touched this. So I think CMSS is so important because so many societies are represented. So how can we, I was like, sounds like kill two with one stone, but how do you get as many people in one group as possible? And I would argue that CMSS is probably the best place for, you know, a high efficiency way to get with multiple societies that all have a different angle on this problem that literally affects every one of them.
Yeah. And I could see how they would come at it very differently too, depending on where you sit in that spectrum. If somebody's presenting you, you know, in the ED versus in your pediatrician's office, you might bring a very different mindset to even the research you've done. It just, you know, huge potential there. We're obviously happy to play that role as you guys do your research initially, but I think also kind of thinking about the ultimate utilization. I mean, what Elliott's able to potentially do with the American College of Surgeons is remarkable. Can we also do that with the American College of Physicians, the American Thoracic Society, and others? And that's where I think we can help PCORI really build what that scope looks like ultimately.
And maybe the answer is instead of starting one by one, come to CMSS and say, hey, we're going to work with you. And then you help us kind of negotiate, for lack of a better term, with each of those different societies.
Yeah, it's probably a lesson learned for all of us. Even the way registries have been built have been very specialty specific. And if you're sort of looking at a broad cross-cutting area, maybe you start with a cross-cutting discussion up front, and we can help facilitate that cross-cutting discussion of here's the issue, who should be at this table, who should be talking about it. Would be really
to speak to the table, Helen, you know, I mean, we at PCORI have learned a good bit about this, about the importance of involving specialty societies in various projects, and to the extent that we ask the questions much earlier now, and we see just even the letter of intent for an implementation project, we ask about the specialty societies and other stakeholder organizations that the applicant will involve to potentiate the project, to have people, you know, as both Rachel and Elliott are saying, earlier on in the project, so that they can be involved in making it more extendable beyond the project. But one thing I'd like to find out, if we have time, a little bit more from Elliott and Rachel, is what that involvement really looks like to you. You know, Rachel, you mentioned an advisory group. Elliott, you clearly have done, you know, extensive work with, you know, the organizations that are involved with your project. But I'm interested to know, you know, are these best structured as, you know, as an advisory group? And, you know, Helen is talked about, you know, having a seat at the table. I just would like more information about what that table looks like.
I'm happy to start. So, and Joanna, I don't think you were on our kickoff call, but I think Ethan was on from PCORI. And we went around the table and everybody introduced themselves who were representing their societies. I'm the president of this, I'm the executive director of that, et cetera. What do we bring to the table? That's one of them. I've worked now with the National Blood Clot Alliance since our very first project with PCORI. I think you really do have to engage with the organization, but also individuals within that group. A couple of those patient stakeholders became co-authors on papers. I've gotten to know people on the board of the National Blood Clot Alliance, and last year I got asked to become a board member of the National Blood Clot Alliance, and I bring a very different perspective to that board. By bylaws, 50% of the board has to be a patient with a blood clot disorder of some sort. So I'm certainly not that person, and I'm the only physician on the board. It's a very different feel, but they felt that I bring a different perspective. Working together with those organizations is critical. We have monthly calls and they're invited to all of them. They don't come to every single one, but I think having one or two key people who are kind of the person who brings it back to the organization, brings the patient perspective or brings the perspective of these trauma organizations, I think is really important.
I guess I would say for us, so at our recent consensus conference, so we had these 10 national organizations, and we have the complex problem also, we're bringing in people from our Child Protective Services agencies, obviously are non-medical, but obviously critical stakeholders. And we also had at the table people who have survived child abuse, people who have been parents of children who are abused, and they all bring their own perspective. So I think part of why it's important for everyone to be there is everybody can't get exactly what they want. And I'm hoping that at least with our consensus conference, people came back and said, well, I heard this and that. However, we also heard this, that at least recognizing that there are a lot of sides to this. And I think ours probably, because we have to go outside of even the medical system, there are even more sides to the story. So I think more is that bringing people to the table from the very beginning to provide their expertise, but also to recognize the expertise of a lot of other people, even non-medical people. And I think that's been a particular challenge for us. People do not see Child Protective Services as a specialty, as people with expertise in the same way we see our own colleagues in that way. And I think sitting everybody at the table from the beginning, from all these different backgrounds, is absolutely key. I said, again, everybody's not going to get exactly what they want. But I think we can come up with something that we all agree is best for children. And I think our whole focus has always been, what we really want is that children don't get abused. And we're lucky insofar as there's nobody who's going to disagree with that. And so as the end point, I think nobody gets a clot, right? I think that we can all agree on and go backwards from there.
I agree.
Great. Thanks, everybody. And we've run a little bit over, and I want to thank everybody that's in the audience for sticking with us. This has been a great conversation. I always learn a lot listening to Joanna, Jane, Rachel, and Elliott. And before we go ahead and say goodbye for now, what I want to do is just give everyone around the horn a quick 30 seconds for a closing thought. We'll go to Elliott, Rachel, Jane, Joanna, reverse order, and then finally back over to Helen, so that way she can scoot over to the plenary that's going to happen on the other line in just a moment. So Elliott, real quick closing thought.
I think dissemination is the most important thing that we do. You can do all the amazing, great, incredible research, and if you've not helped anybody outside of the 4 floors at Johns Hopkins Hospital, that research has not really done anybody any good. So I think if we're not disseminating, we're not doing our job.
Awesome. Thank you, Elliott. Rachel.
I have to say, I almost have to completely just echo what Elliott said. The idea of funding and trying to bring about dissemination instead of assuming that it's going to happen is, I think, the most important thing that PCORI can do. Because I think previously we just assumed if we had good research findings, people were going to do them. And I think it's very clear now that this has to be a very intentional process.
Great. Thank you. Jane, any closing thoughts?
Sure. So, I think it's really important to us at PCORI to reach people with our PCORI funded results, especially people who can use them. And I think we've really found working with specialty societies and other stakeholder groups is a really important way to reach those audiences. So we just look forward to continuing that work together.
Great. Thank you. Joanna?
Thanks, Greg, and I'll just add my thanks to everyone for coming to participate in the conversation. I really do learn a lot. We know what is the goal of what we're doing, but hearing from people like Elliott and Rachel who are in the trenches and making it happen is just so interesting. And I think this is really what makes it work. So thanks very much.
Yeah. I'll add my thanks as well to CMSS for the opportunity, to the speakers for joining us, to the attendees for sticking through it and listening to us. And Helen, over to you. Take us home.
Great. Thank you so much. I'll just say that this has been wonderful. It was funny, maybe because it's election season, I'm not sure people realize Emily's list. Emily is actually an acronym, which stands for early money is like yeast. So I really think in many ways, PCORI is that early money that can be like yeast. And I hope we're part of that. I'm going to mess up the analogy, but I hope we can serve as one of those effector arms to kind of get the early money and push it out to really make a difference and disseminate and implement. So with that, thank you all so much. I'm going to scoot over to the plenary session. Please feel free to join us. It should be wonderful. And thanks again for PCORI's support. And we can't wait to push this out to our societies.
Thank you.
Great. Thank you. Everyone,
Thanks,
have a great
everybody.
day.
Great.
Enjoy the plenary.